had a quick question, Scott.
Sure, yep.
On the one that asks about severe MR, what do we not see? At first, I had said the septum, we wouldn't see the septum bowing from right to left. But then I ended up picking dilated, or I think it was LV, RA, and RV, just because, well, I didn't remember talking about right heart dilation with MR. So then after,
We
okay,
definitely do get right heart dilation because it does back up. So you're dumping all that fluid back into the atria,
yeah,
and it's trying to get it out. It's sort of swishing back and forth. You got to remember you keep having blood coming in and in and in, and it's kind of just backing up again because it doesn't go out efficiently. And
okay,
so
that
over
makes
time,
sense.
we do get a big back up in the left atria that backs up through the lungs and then into the right ventricle. So yes, we do get a lot of dilation and pressure buildup in the right heart also.
Okay, that makes sense. I figured I had missed something with that, so I just wanted to make sure.
Yeah, and the intraatrial septal bowing, if we were to have bowing anywhere, it's going to be from left to right because that's where the pressure is most increased. If you
Totally,
have
that
a
makes
left
sense.
shunt, that means that you got a significant pressure buildup in the right side of the heart, which I mean, it could happen, but it's a lot less likely than these other scenarios.
Right. Okay, thank you.
Okay, so the incorrect or the correct answer, because it was, what was it?
Yeah, so I'll just read it. So the severe mitral regurgitation, we see all of the following except. So we do see intraatrial septal bowing from left to right. So it looks like I get both options. Right to left was the option that was not. That was the exception. We do see dilated LA, RV, RA, and we do see signs of pulmonary hypertension. So what we don't see is the right to left septal bowing. We do see left to right septal bowing because that's where the pressure is elevated the most. Everything's about pressure. Good. Okay, and the last one there, the color M mode, that showed, and that was actually a picture that we showed in the slides, was mitral prolapse on that color M mode. Looks like a couple people chose MR due to flail leaflet. If that was a flail leaflet, it would be regurgitating the entire time that the valve is closed. It wouldn't be just at the end of the cycle. So if it's at the end of the cycle, let me throw it up on the screen here.
Isn't the flail leaflets when there's like an artifact of dots going through?
You can see that in spectral Doppler, but that's just one that you would see. So the flail leaflet, the point is that the valve never really coapts. The problem with prolapse is the valve initially shuts properly, but then it slips down until it opens up a gap. A flail leaflet, the leaflet tip automatically just goes, and it's immediate. As soon as the valve shuts, it never actually shuts in that area, and the leaflet just opens and points the wrong direction. So we get an immediate regurgitation at that point.
Okay.
So let me just share the screen so you can see the picture of it. So that is so this here, that is a over the entire, so this is the time that the valve is shut. Okay, so you can see your E, your A, and then valve shuts. We're supposed to be closed during this time. This regurgitation is happening on about 2/3 of the way through the cycle in this case, but often it's more than that. But a flail leaflet would be the entire time. It would go all the way across that. All right, good. So overall, it looked pretty good. There's that. Start our presentation. Any other questions before we get going? Today we're going to talk about prosthetic valves. Prosthetic valves are kind of a fun topic, I think. I like different things. Most people are just happy to see stuff normal. I was the weird guy in the lab that, hold on here, just label this real quick. Okay. yeah, I was the weird guy in the lab that liked to scan the weird stuff that came in, because echo, I'm not gonna lie, if you're in a clinic and you're doing bread and butter echo, meaning that you're doing just, like 6 to 8 resting echoes per day, you're doing a lot of the same stuff. A lot of your patients have similar pathologies. They all kind of blend together at the end of the day, and a lot of people are quite happy with that. I had a colleague that used to be in medical massage therapy, and he had repetitive stress injuries coming on, so he quit that and came into echo. I'm like, dude, like echo's like not much better. It's like we have repetitive stress injuries too. And you can kind of work around stuff with massage. But anyway, he was the kind of employee, he just wanted to come to work, do his job, go home and be happy. He didn't want to have to think about anything after work. He didn't want to have to think about what he did in that case. Just wanted to do a good job and just, see a bunch of normals. And there's people that are completely happy with that. I'm not that person. I get bored, so I start doing other things, and I like the weird stuff. So if we got a case, for example, that came in, patient had situs inversus totalis, meaning the entire body was mirror image from what you normally develop as. So your heart was on the right, normally for that patient. The liver was on the left, the spleen was on the right, stomach was on the right. Did I say that correctly? The liver was on the left, spleen was on the right, stomach was on the right. Just it was completely backwards, the entire body. And they were normal. If you were to look at them just as who they are, it was normal. The heart was normal, stuff was normal. It was just backwards from what we're used to looking at it. So when I scanned it, I was left-handed scanning usually. So in this case, I put the patient on the right side, and I had to scan with my right hand as if I was scanning with my left hand. And every time that I took a picture, I had to display it on the screen the way that the cardiologists are used to seeing it, so it wasn't all backwards, and so that they could properly evaluate the heart and see what was going on functionally with the heart. So I had to take the pictures, but then afterwards I had to label the images how I was oriented and how I had my transducer and the indicator and all that kind of stuff. So it was a very tedious process. So, most of our techs, when it was offered to take that opportunity, they all jumped away. They're like, heck no, I'm not touching that thing. Yes, it took me a long time, but it was a really cool experience for me. So I like to jump into those kinds of things, and I would suggest as a student that if you can get involved in these weird and different things, I think that's a good thing. It shows your management that you're interested in being a go-getter and kind of getting into the stuff that other people don't necessarily want to do. That's always a positive to a manager. I did that once in gross anatomy too. I was taking a gross anatomy, and they needed a sagittal section cut on this person's head. It was a cadaver, and so we had to do a sagittal section right down the middle and cut it open and split it apart and stuff so that for teaching. And they're like, who wants to do it? And I like jump in, I'm like, sure, I'll do it. And everybody else is like, whoa, heck no. And then he tells me, he says, if you screw it up, you fail. So I'm like, yeah, whatever, I don't care. So it's fun to be able to get involved in that. It's not everybody's cup of tea, and I'm not saying that everybody has to do it. But it does make you stand out a little bit as far as your management and stuff is concerned, and especially if they see you that way as a student. They want people who are willing to adapt and to do different things. They don't necessarily just want somebody who just wants to do the bread and butter basics and not get involved in all the other stuff that comes. Because the reality is, in the lab, you have to get the work done. So that's my soapbox for the day. Or should I say for the moment? I'm sure I'll have another one. All right.
Did you use like a saw to cut through the skull? What did you use?
Yeah, it was interesting, I thought. This again may not be interesting to everybody, but we actually had a reciprocating saw. So you've seen those little Dremel tool type saws, they kind of go back and forth real fast, and they got the little blades. We do that goes through the skull and only goes through to the skull itself. Now the medical ones, they actually have a safety so that when you actually break through and it senses it, it stops. And so it's kind of intricate to work with. And then after that, we actually had you've seen the saws for like a miter saw. So it's like a big flat bladed saw, little tiny teeth, just straight. all along it, and so we'd use that to cut the rest of the way through it. So I had to cut through the bone, and then we had to saw the rest of it, and then kind of split it open so that you could see the anatomy. And it was pretty cool once it was done, but yeah, not everybody's cup of tea. You know, a little bit of a scalpel stuff in there, just some cutting and so forth. But the interesting part of the thing that we ran into, because we didn't really look before we started cutting. So I started on the jaw and started cutting up, and then I got to the spot and I could not get through the teeth. And I'm like, man, the teeth just that hard, or what's the deal? So we peeled the lip back, and they had a denture in still. It was their denture that I was running into. So yeah, it's, you know, the surgical tools, even in surgeries where they're doing hip replacements and stuff like that, it sounds kind of cruel and gross or whatever, but the tools are very much like carpentry tools. They're just stainless steel, but it's kind of interesting. So on talking about the valves, so I just threw a few examples up here, and I try to disperse pictures throughout this presentation because there's a bunch of different types. You're going to have some generalized types of valves, but each manufacturer is going to have their own, you know, rendition of it, their own version of it. And, you know, over the years, as we get better and better, they're finding improvements to the technologies and how they design and develop these things. So they'll be stronger, but they'll also be less likely to develop places for blood clots to attach to and things like that. So we saw a ball cage type of valve, which is a mechanical valve, on last, I think it was last class or class before, we showed that image. And remember, it had this sewing tissue, let me grab my laser. It had this material all around the entire structure. It was all around the whole thing. So the older ones are more like that. The newer ones have more smooth surfaces. And we know that a ball valve's issue is that it can destroy a lot of blood cells. Destroying blood cells promotes thrombin chain to go and to cause the blood clot reaction to start to occur. And so you'll notice that some of these changes have less of that structure to hit and do damage with. You know, you can see that this ball sits more inside rather than, you know, shutting down right on top of the loop. So various ways to do it. So this is a ball cage. This is just a different style of a ball cage. This one here is what they call a tilting disc. So this, you only see it in cross section both ways here. But this plate here is a round plate that when it shuts, it seals that hole. Same thing here. So this just tilts back and forth. It's got this strut mechanism here that helps it so that it doesn't open too far, or, you know, it keeps it going where it should be. The one on the bottom is what we call a bileaflet valve. So this has two little leaflets, and so when it's open, it has 3 holes, whereas this one up here has 2 holes. This one here, the ball cage, the flow is going to go around the ball as it comes in. And then we have a stent valve. So this would be like your TAVR type of valve, where it's a stent and they place it into there and it kind of anchors itself to the walls. And then they have kind of a tissue type of valve structure there with some struts that come out. So they got rigid struts that hold those valves leaflets in place. They try to mimic what a real valve would be like as much as you can. So those are just a few examples. Okay, let's talk about the pictures first. So here's an X-ray of somebody with what looks like a tilting disc. Okay, so a tilting disc, remember, it has that structure in there. You can see that there's a disc-like structure in there as well. So we see the ring really well. We see some of the structure, but we may not necessarily see on an X-ray the valve itself super well. Somewhat, we do. But that's how they might see it on an X-ray. Notice also on that X-ray, notice the sternum. What is that stuff on the sternum? Sternum's over here, by the way. This is spine on the back. What do you think these are?
Are those like wires?
Those are absolutely wires holding the chest cavity back together after they've done open heart surgery. Okay, so you're going to see these types of things. You can imagine trying to scan around this kind of stuff. You know, that's obviously part of the sternum. We avoid the bones, so it's not that bad, but you're going to be working around and through stuff that that has been done on a patient sometimes. Okay, this image to the left is a bileaflet valve. So you can see there's two flat surfaces, kind of a ridge in the middle here, where they tilt from and close. And so when it opens, those valves open up. I mentioned before that this is the annular ring that we sew to the heart itself, and these little dots along here are usually suture marks all the way along it. And so when that opens, I've actually got 3 holes. So I got one on each side, and then I got a thinner one in the middle, because that's an example of a 3D valve, looking at it from the upstream side. So flow is going to go through that, through to the other side. Okay, so echo is the modality of choice because it is non-invasive and it has the ability to assess anatomy and function, okay? Whereas other things like the chest x-ray, they can see that the valve is there. They can see the structure of the valve. They can see that maybe it's not broken. Maybe they can see if it has a fracture, perhaps. We wouldn't be good at seeing if the valve itself has a fracture, but maybe x-ray is good at that. What can you tell me on the x-ray about how the valve is attached to the annulus of the tissue? Can you say anything about it? We can't. Okay, we can't see it. We can't see the soft tissue. We only see the hard stuff. So echo's good at seeing the hard structure. We're also good at seeing the attachments of it. We're good at seeing if the valves functionally are opening and closing like they should, if the movement is appropriate, as well as the preparation for the surgical replacement in taking measurements of annulus and things like that that help to size these things correctly, because the size of the structure is really, really important to be accurate to the size of the patient. As we know, all the patients are different sizes. Okay, yeah, this is an older table, but so in the prosthetic section, kind of goes over just a list of valves by partly manufacturers, but partly by type as well. So we have a group of valves called mechanical valves, and then we have bioprosthetic valves as well, which actually have tissue types in those that they build it with. So let's just talk briefly about the mechanical. So mechanical is something that's all man-made. The entire thing is man-made. So they've got the ball cage, which we talked about. So ball cage classically was Star Edwards, is the company that made it. I'm not going to require that you know all of these things, but just kind of be somewhat familiar with the names and kind of how they're associated with certain things. But the names are usually just a manufacturer of it. Even though the Star Edwards makes a caged ball, there are other manufacturers that make a caged ball as well. The single disc, there's a Jort Chili, Medtronic Hall, Omnicarbon, and Lily Castor. So you may have heard of these companies before. Probably the most common one is probably Medtronic Hall that you might have heard of, or maybe you haven't heard of any of them. That's okay. So that's a single disc. That's again one big flat disc, like a plate that kind of opens and shuts on a pivot point. Bileaflet disc, as we just talked about, the most common one is St. Jude. So St. Jude is the one that invented the bileaflet disc, but there's Carbomedics, and there's probably other manufacturers now making them as well. Onyx is a valve type. I'm going to show a little video from Onyx here in just a few minutes. And then we get into what we call the bioprosthetic valves. So the tissue type of valves, we have an autograft or homograft, which is human. Okay, they use human tissue like fascia and stuff in different areas that they'll take off, or pericardium sometimes. It is a fibrous type of tissue that's actual human tissue that they make the valve with. Now they make the structure with man-made materials, but the valve itself is that fibrous tissue. They could also use porcine valves. So porcine is pig valves, okay, and bovine is cow valves. So we can use pig valves, we can use cow valves. They've said that the pig heart is actually most closely anatomically correct and oriented and stuff as compared to the human heart, with the exception of the branches coming off. It has two brachiocephalic arteries, whereas humans have one, and then we have a left common and left subclavian on the branches. But the heart itself is pretty much the same, and it's similar in size and everything. So big valves actually work very well with human stuff. All right, so I'm not going to go through the entire list. The homograft at the bottom is a human graft, okay, and they can actually take material off the same patient to make that valve if they had to, or taking it off of a different cadaver, so to speak. Okay, so this is just a couple of another things. So ball and cage, pretty obvious. That bileaflet valve, and this is one of those bioprosthetic valves. It could be porcine, could be bovine. I'm not sure what it is exactly, but this tissue here is actual tissue.
Hey Scott, I have a question.
Sure, yeah.
This might be a dumb question, but if they do a valve replacement in like a child, does their heart grow, or do our hearts stay the same size?
And that's a great point, because when they do a child valve replacement, they have to take into consideration that child, it's like I buy shoes for my kid. He's growing, he's getting a growth spurt. We always buy his shoes too big because he's going to grow into them. And probably grow out of them and wear them out soon. So yes, kids, they do have to have, so when kids are very young and they need to do surgeries, and you'll talk about this with Mark with the congenital section in the fall. But when kids have these surgeries, some of these surgeries are actually multiple phase surgeries over multiple years. As the child grows, they do need to do valve replacements. So sometimes they'll put off the surgery. They'll try to maintain them medically as long as they can before they actually have to do the replacements, because we know that there's only so many times we can crack the chest open and do it again. Okay, so I was just listening to a commercial. It was on this morning. I hate commercials, but I'm stuck right now watching local television. And I keep having the Shriners commercial come up, and we got these two kids on there. One's an older kid, one's a younger kid, and they're like, "Yeah, I just had 13th surgery, and well, I just had my 17th surgery." That's a reality that these kids have to deal with sometimes. The fact is, though, that if we didn't have those surgeries and those procedures, those kids would have not survived to this day and age. So it's pretty cool what we can do, but the reality is, to your point, that yes, we sometimes have to redo these things, and we will start. You don't want to overly size it significantly, but there is consideration taken for the size of the patient, because they will grow and they are going to need a bigger valve. If we left a small valve in, they would effectively have a permanent aortic stenosis, for example, or a mitral stenosis.
Yeah, I know.
That's not adequate.
I know a little 2-year-old guy who had his aortic valve replaced, I think with a bovine valve, when he was like under a year old. So I just wondered if he's probably going to have surgery again, or
Definitely.
Yeah, I figured.
Definitely.
Okay.
Yeah, it's sad when you think about it, but again, the alternative is that those kids wouldn't have survived, and that's why we have the problem we have in the industry, that we don't have enough people that know congenital stuff that well. Because these people are surviving their surgeries, which is awesome. But now we got to figure out how to teach the adult techs how to deal with those things instead of always pushing it back to the pediatric lab. It's a good point.
Hey Scott, I had a question before we move on. In the new graph that they have in the book, it goes over stentless, and I didn't know if your graph had a stentless, but I was just curious what that is.
Yes, stentless graft. So there's different. So the graft itself. So this is an example of a graft right here. Picture A. So you have a valve that's implanted into here. This could be a graft, or it could just be a native. But sometimes a graft is a tube that's attached to it, and sometimes those tubes have a material that's in there, and sometimes they have stent material, just like we have placing stents in coronary arteries, for example. And so, yeah, some of them have stent material built into it, some don't. Stent is usually a metallic type of a material. So that's all a stent valve is.
I'm sorry. I just realized I said stentless and I meant sutureless.
Oh, yes. Yeah, so the ones that they actually do open heart surgery with, they're typically sewing on. But yes, now we have TAVRs, which are valves that go in via cath lab, and they'll balloon angioplasty the valve out and put the stent in that has a valve inside of that stent built in. That's a fairly new procedure, and it's certainly picking up steam across the country. Even it started in places like Duke Medical Center and Mayo Clinic and OHSU. Those are the places that started doing all that. Now we've got it at Deaconess, we've got it at Sacred Heart, and I'd say every decent sized community around the country has TAVRs being done now. So the nice thing about that is you don't have to cut the chest open, you don't have to rewire the sternum back together. You can go in through various methods, and we'll show that, where they can go in a cath lab, balloon angioplasty it out, put the valve in its place. You can even redo the valve once. So if they had a stent valve in place and it failed, they could actually put another stent valve inside that stent valve if they had to, but they can only do that one additional time. So yeah, we'll talk about those going through this, but there's all sorts of different kinds of things, and they're always trying to come up with something new and improved to be able to fix the things that we have. So kind of cool. All right, so again, just a quick review. We went over it on the chart already, but basically you have three types of mechanical valves. Again, mechanical valve is a valve that is rigid. It's all completely man-made material. So that's the cage ball, the single disc, and the bileaflet disc. Okay, and then the tissue again, bovine, porcine, or porcine, and homograft. So again, bovine is cow, porcine is pig. Think of P for pork, and homograft is human. And then again, just a few more pictures of that. So try to throw a lot of pictures in these. Okay, so the different types of styles they have different purposes. So you just mentioned that you knew that young child that put a mechanical valve in place. So the question is, why do we want mechanical versus a bioprosthetic? Which one's better? The answer is it really depends on the situation. It depends on the valve placement itself, and it depends on your plan for how to replace that valve in the future, because the reality is these valves only last 15 to 20 years, maybe 10 to 20 years.
Oh, he actually had bovine. I might have misspoke, but
okay.
his was tissue.
So, but that depends on what they want to do. So, so we'll talk about that as we go, but keep that in mind that there's a reason that they choose these types of valves over other types of valves. So this one may be, for example, in the subcoronary position, might be a freehand valve, as quoted out of the book, or as part of a full root and valve replacement procedure. So jumping back a couple of pictures, that picture, again, these valves are kind of just valves themselves. These are two bioprosthetic valves. These are all other mechanical valves. This is a valve that's built into a tube, okay? So this is a conduit type of valve. So again, there's just different types for different situations. Okay, so expectations dependent on valve type. So the ball and cage one, so it moves by that ball moving back and forth. The blood, as it pushes it out of the hole. As the blood flow reverses, it comes down and seats itself in the hole, closing that up. That one has classically caused probably the most red blood cell damage. So that again is problematic because we spark the cascade of blood clotting. So with the mechanical valves generally, if they get a mechanical valve, they always have to be on blood thinners. Okay. Has anybody ever known anyone that was on blood thinners? It's not a fun process. It's something that especially if you're on Coumadin. Coumadin is one of those drugs that it works great. Coumadin happens to be the same thing that they use in rat poison. In other words, they actually bleed out by overdosing them with a blood thinner. That's how it kills them. So it's a very sensitive medication. It interacts with like everything. So if you change your diet, It changes your blood clotting. So these people always have to go in and get the blood checked to see what the clotting factors and stuff are. If they go in for any kind of surgical procedures, they have to kind of, portrayal how they use that. But the risk is if we put a mechanical valve in, we're doing a lot of red blood cell damage. We use the blood thinners to prevent clot from forming. But if we have to do something else or something gets out of control, these patients can easily blood clot, causing obviously all sorts of issues. So it's not the best thing. The reality is if I buy Tesla's Cybertruck, okay, I don't know if you've seen anything about Tesla's Cybertruck, but I'm looking at trucks right now. And I'm like, is diesel even going to be around in 5 years? I don't know. If I buy this brand new diesel truck, I spend a ton of money on this thing. It's probably going to be a big paperweight. I buy the Tesla truck. The Tesla truck, one of the cool things is it has, and why they did this, I think it's just overkill, but whatever. It's resistant to a 9mm handgun, the body of it. So you can literally shoot at the thing and not damage it. I think the idea from Tesla
Hey,
is
Scott,
that it doesn't damage it. Yeah, go ahead.
you don't live in the right neighborhood or the wrong neighborhood if you don't know why it's resistant to 9mm handgun.
Yeah, that's probably true. That's probably true. I mean, I would totally love it. I think it'd be fun to have. What my point is that we've got a truck that has the body that's like literally resistant to a handgun, right? And then I don't know if you guys remember the old Dodge Neon. When the Dodge Neon car first came out, they prided themselves in making it environmentally friendly. And so the body of your car, the car itself, was going to be biodegradable by a certain point. And it wasn't like an extensively long time either. So when I put a bioprosthetic valve in versus a mechanical valve, I kind of want the bulletproof. I kind of want it to last for a long time so that I don't have to have my chest cracked open and done again. But the advantage of having a bioprosthetic valve is that I don't have to take the blood thinners for that long. You do for a certain period of time through your recovery, but I don't have to take it long term. So that's a plus. The downside is it's probably going to have to be replaced 5 years sooner. Okay, so there's a benefit outweighing the risk scenario and what the patient is willing to tolerate for the rest of their life. And then again, taking into that age into consideration, if I had I'm going to say an 80-year-old person comes in for a valve replacement, giving them a mechanical valve may last them the rest of their life. Well, let's make it younger. Let's take a 70-year-old patient. That may last them the rest of their life. If I had that same 70-year-old patient and I had to put in a bioprosthetic valve, there's a chance that I might have to replace that valve again before they finally die. The problem is by the time they have to have that replaced at 85 years old, if the patient hasn't died already at that point, then they stand a good chance of dying during the procedure itself. So those are things that they have to take into consideration. Obviously, young patients, they have a different method of looking at these things depending on growth and stuff like that. Okay, so single disc. So we talked about the ball and cage. Single disc opens at a point, leaving an angle for when the flow changes so that it may be pushed closed. So with that valve, and again, we'll look at, so they don't open totally so that they're straight, so that, if the flow is coming down, they always leave a little bit of a tilt to it, because when the blood flows through, it goes nicely, but when it shuts again, there's enough of a tilt that causes that to shut. So there's a slight angulation on each of these valves. Both the single disc and the bileaflet disc have that, so that they can be closed effectively when the flow changes direction. If you left it so that it went perfectly straight open, there's a chance that the blood just flows by it and doesn't actually force it to shut. That would be a problem. Tissue valve is going to appear much like the native valve even when we scan it. So sometimes you can mistake it for a normal valve with maybe some calcification around the annulus. If you didn't know that they had a valve replacement, you could be scanning your patient and be like, something just doesn't look right here, and then you find out that they actually had a valve replacement. Now, taking your patient history, you should be finding the stuff out, like what types of surgeries and stuff they've had. The funny thing is, as you get experience asking patients about their history, sometimes you'll ask them like, "Have you had any previous surgeries?" And they're like, "Nope." And you start going, you're doing your thing, you're scanning along. You're like, "What's this scar?" "Oh, well, I had my gallbladder out, or I had my liver resected." It's like, and you don't consider that a surgery? So patients do not always tell you the entire truth, just partly because they're nervous, they don't know what's going on entirely, and they forget. I mean, some of those things they've just had for so long, they're like, "Oh yeah, I guess I did have that." So pay attention, and when you're scanning and you do see something, I've personally had patients that had a mitral valve ring in. So we showed that ring the other day with mitral regurgitation. So it's an annular ring that gets sewn on to the native valve, kind of bringing it all together and holding it in place. And it's got a very distinct look when you're looking at it. So you'll see the anterior mitral valve leaflet coming down, and you see this really bright dot right in the middle of it, and everything is hinging from that point. That's classic, and you'll also see that on the posterior wall, but a little bit closer to the wall. It looks like a mitral annular calcification at that location, but you can have patients that you didn't know had that stuff going on, and then you'll ask them, it's like, "Did you ever have like a ring put in your valve?" And like, "Oh yeah, I did, yeah." And so, look at those things, pay attention to those things. If you think it doesn't look like a natural process, ask the patient, like, "Did you have something done on this valve, or what's going on?" If it's a no, then you're like, that's odd. Okay, so we're gonna so in the valve procedure, what do we do in echo? What's the take-home message when you look at a replacement valve? We want to know, is the valve seated where it's supposed to be? Is it sewn on correctly and not moving? It should be well seated in place. And we want to know, is the leaflets functioning the way that they're intended to function? We don't want to see broken pieces. We don't want to see things coming down and getting stuck. We don't want to see them stuck closed. Those things are all bad scenarios. We don't want to see stuff growing around the outside of it. So we're always going to look all around the valve as much as we can. So I mentioned dehiscence of a valve yesterday, which is when the annulus tears away from the wall. And in these valves, we talk about dehiscence even more. We're looking for a rocking or an independent motion that's an indication of dehiscence. So again, dehiscence is that detachment from the side, from the wall. And so we're looking at the entire valve structure. It should be seated, and when the valve's opening and closing, I should see the leaflets doing their thing, but the annulus should be stable. It should be rigid. If it's rocking and moving like this, the ring, then that's an indication that we have dehiscence and it's torn away from the wall, which means that I probably got blood flow going around the outside of the valve, which is not normal. We're going to assess, again, looking at stuff attached to the valve, things that are going to be kind of gumming up the mechanics of the leaflets themselves. So we're looking for thrombus and vegetations that are attached to it possibly. Valves are a very specific size to the patient. So again, with that consideration of a pediatric, as they grow older, we need to size that appropriately and likely replace that as they grow. Okay, so the native or the prosthetic valves themselves, if you're looking at the simple flow velocities from a native valve to a prosthetic valves have a higher pressure gradient and a higher velocity, slightly higher than a native valve typically does. Simply because we're putting it in the space that's there, we're putting something a little bit more narrow inside that, so that narrows that opening just slightly. And so that's why we get those increased velocities and increased gradients. When you do a valve replacement study, patients often have a little card that they carry in their wallet that tells exactly what valve they have and what the size of that valve is, because I could get a bileaflet aortic valve, but it might be, there might be 4 or 5 different sizes of that valve depending on the patient you're scanning. And so having those exact numbers is helpful in assessing whether that valve is still functioning correctly or if it's starting to fail, which is important. All right, so those values are usually, you can look those values up if you have patients that have those valves. And often the cardiologist has kind of a chart of that inside the patient chart anyway, as they're interpreting the study. It's easy to overestimate a gradient on a bileaflet valve because, again, it has those 3 orifices. That middle one is more narrow than the others, and so therefore you actually get a bit of a higher velocity through that center one. So taking the mean velocities and the mean gradients and stuff like that is important. So we're going to be doing a lot of tracing on those valves. So remember, any of these types of things, you're doing at least 3 measurements on. If it's AFib, it's 5 measurements again. So you would treat this just like a stenotic valve. You're going to start doing a lot of measurements on it. Pressure recovery concept is that the kinetic energy is converted to pressure downstream. And then the question with pressure recovery is how quickly does the pressure recover after the initial drop in pressure? And I just throw that out there as a generalized statement because it's starting to pop up as a concept in the books. Okay, regurgitation. So small amount of regurg on the valve itself. So we're talking regurgitation in the valve leaflet area. A small amount is normal on the valve itself. In fact, sometimes the manufacturers, and often the manufacturers actually leave a little bit of regurgitation. Just like MR goes through the whole atria and kind of swishes around and swirls around and cleans out any stuff and keeps movement going. The small amount of regurgitation on a particularly mechanical valve actually helps to wash the surface of those valve leaflets. So that's a good thing. We don't want it to be big. We don't want it to be like a moderate or severe, but a small trace to mild amount is actually a normal process for those. Okay, so it kind of washes that valve leaflet off. Leaking around the sewing ring or the outside of the valve, though, is abnormal. You will see it initially, like immediately after surgery, and that's okay, but it should close up fairly quickly after surgery. So if I'm scanning somebody a week later, for example, or a month later, and they've got leaking going around the outside of the annulus, that's bad. You do not want to see that. That's when we're looking for that dehiscence or that rocking motion of the valve as it's implanted in its location.
So you said a week after the procedure, the leaking around the ring is normal?
Yeah, I don't know the exact time, but immediately after the procedure. So I'm talking, they just finished the surgery and we're using a transesophageal during surgery. You're going to probably see some at that point, but within days it should be sealed back up. So it should be minimal to none. But I'd say about a week or more out, you should not see. It's really abnormal to see leaking around the outside of a replaced valve. Okay, some valves like pericardial valves might have a central leak that resolves over the initial weeks. So some of these valves, particularly the bioprosthetic valves, because of how they've made them, so it's just like a, how can I relate it? You know how some things just take time to break in? So like a diesel truck, I mentioned buying a diesel truck. So if I bought a brand new diesel truck today, you would think that that would be like the optimal running. You know, it would run most optimally right out of the factory. The reality is that it takes several hundred miles initially for the engine to kind of break in and find its sweet spot before it actually drives most efficiently. And it's the same thing with these valves, because you can, you know, because of how they have to make them, there's a certain amount of rigidity initially that allows for a little bit of a leak at the beginning. But once that valve starts to get used to that process and it gets used frequently, then it kind of breaks in to the point where it seals up that leak. Okay, but it's because of that rigid nature of it initially that that it has a tiny leak initially.
Like a good pair of Chacos.
Yes, yes. Yeah, my chocolates are finally getting more comfortable. I can't say that they were super comfortable when I first bought them, but I paid a lot of money, so I withstood the pain.
I just ordered my first pair yesterday because everybody in Twin Falls had them, and
Yeah.
I am so excited.
Yeah, don't be totally I think the new ones are better than when I got mine. I can't say they're as comfortable as I thought they should be, but it took some time. But once they break in, they are very comfortable. But there is that initial break-in phase. Yeah, hiking shoes, running shoes, stuff like that. They always tell you not to go on a hike after you buy a brand new pair of shoes because you're going to get blisters and that. You have to get used to it. Same concept. Okay, after valve gets replaced, it should have a baseline study done with measurements and Dopplers and stuff like that. So we always want to kind of get it fairly soon after surgery to see what is normal for that patient. And then we have something to go off of if something changes. So you always want to have a good baseline study. And then the continuity equation can be used to measure the effective orifice of a prosthetic valve as well. So we know that what goes in one area must go at another area. So we can take like an LVOT diameter in cross section and pulse wave and with VTI and all that, and take that and compare it to either the flow going through an aortic valve or even the mitral valve, because the flow still has to go at both locations. We can use that continuity equation to extrapolate what that valve area actually is.
So we're,
Go ahead.
I'm sorry for cutting you off. So we're not using pressure halftime?
I think usually you're going to be, I can't remember if we did pressure halftime all the time or not. That's been a while for me. With these valves, you're definitely going to be tracing the waveforms a lot. I think you'd still probably take the pressure halftime, but you can use a continuity equation for that. So I think we still use it from what I remember. That's been a while though.
Because it seems like it's opposite now. It was like, you don't use the continuity equation as much, you know, when doing the mitral valve area with the last discussion we had, but then now we are.
Yeah, on a native valve, that is true. Feigenbaum kind of threw it out there, so that's why I put it up here on the slides. Yeah, I think you can still use pressure halftime because we still use velocities. You're still going to trace the waveforms. You're still going to get your mean pressure gradients and your mean velocities and stuff like that. In fact, you're going to probably rely more on the mean pressure gradients and stuff than you are on exact velocities through those. But they do all have their own sets of numbers, and they have a complete set of numbers just like anything else does. I just threw that statement out there because he put it out there.
Well, it is a question on the study guide too. So I'm like, which one is it? You know?
Yeah, there you go. Okay. I had a thought that I wanted to share, but I can't remember what it is now. It'll come back to me. It's all good. So
Sorry, that's my fault.
No, you're good. So what I want to do now is show you a video. It is a 15-minute video. I guess we can go through it. We got, you know what, let me come back to this. So let's get through the rest of it and then we'll come back and show the video at the end, or you could just click on the video on your slides. This video is it's an Onyx valve, and just keep in mind when you listen to it that it's actually a marketing thing for Onyx valves. So if it seems like it's the perfect valve, that's because the manufacturer wants you to think it's the perfect valve. Just saying, is it exactly what they say it is? Probably not all that. They suggest that it lasts forever. Yeah, it's like the lifetime warranty on my car. Not ever going to last forever. Anyway, we'll come back to this. Okay, so how does echo apply to these valves? Again, any of these valves. Oh, this is the thing I was thinking of. When we do a mechanical valve and you're doing an echo, how do you think it might be different from scanning a native valve? Just thinking about what the valve is, what it's made of.
We would have lots of shadowing.
Yes, definitely. And that shadowing is going to cause what to happen? That's not to see what.
You wouldn't have color flow.
Potentially, yes. So in, oh, that is. Potentially we have a lack of color flow, you know, especially those small jets. So if I'm looking at a mitral valve, for example, and it's got a leak on the posterior aspect of it, I'm not going to see it from peristernal long axis. Okay, I may not even see it very well from apical four-chamber view. So I might have to try to find alternative views to see around it. And when we're looking for leaks around the annulus, you got to keep in mind that the far field of that, the deepest part of that valve that I'm looking at, I may not be able to see beyond that. So I have to find a different way around it. So we have to be even more creative with our echo windows when we're looking at these prosthetic replacements. That's the thing that I needed to point out, which is an important part. So you have to keep in mind the artifacts, and then you'll get to know how the valves are typically seated and angled and stuff like that in your various views. For example, when you're looking at the mitral valve and peristernal long axis, it doesn't come straight across. It actually comes up more towards, and it shoots towards the septum. So from more towards the apex, I can actually see into it pretty good. But if I'm really, really high, it's going to be more perpendicular to it. So you just have to move your transducer around to different rib spaces, different windows to see through and around those structures. Okay, so the application of echo begins at surgery, and I would suggest even before, because we often do the workup for the surgery. TEE is done beforehand, so transesophageal. It can be done before the surgery and during the surgery. So they can be in with the transducer down the throat, imaging from the back as they've got the chest cracked open. You can actually scan on top of the heart as well. Tammy was just telling me a story about this just the other day in the pediatrics, that she was scanning this thing and they're having a discussion in the lab because Mark couldn't see what was going on in there. And Tammy's like, oh, we'll go back and look at my images because I was scanning right on top of the heart, and this is how you'll see it. So we can scan right on top of the heart as well with proper sterile technique, obviously. These help make decisions regarding the type and the size and the feasibility of repair. Okay. During the surgery, we assess for the success of the surgery and the completeness of it. So we make sure air bubbles are out. We make sure that things are seated the way that they're supposed to be, that there's not a ton of regurgitation, and that the valve leaflets are functioning the way that they are supposed to before they actually close everything back up and send the patient on their way. Following the surgery, we do baseline, and that's where we establish kind of its baseline and the success of that procedure, and look for any flow changes that might have occurred because of the valve replacement. Intraoperative echo changes the operation plan in about 15% of cases, and a revision in the plan in about 5% of cases. So sometimes what we see on the echo changes the outcome of what they plan to do for their surgery. All right. Welcome to 2021. If you want a second opinion, I'll ask my computer. AI is coming. AI is here. I think it's kind of funny. I was joking with one of my doctors several years ago up in Canada. I needed to get a medication for something, and I just happened to be looking at his board, and he had like these drug rep posters all over the place, 2 or 3 of the different ones, and it was for various disease process. And like, I was joking with him. I'm like, you know, to be honest, because I was working in pharmacy at the time, like, you don't even really have to know what these drugs are. You just have to like throw a dart at the dartboard here and pick one of these drugs to, you know, fix this liver problem or that. You know, he kind of laughed. He's like, yeah, you're kind of right. You know, the doctors do know what they're doing, and I do trust them, but sometimes we make it kind of idiot proof in a way. And the drug vendors, they advertise it obviously in such a way that it kind of sometimes makes them a little bit biased towards certain drugs. Way back in the day, they don't allow this to happen anymore, but if you wrote a prescription for a brand name, you had to prescribe that brand name. So when it came to the pharmacy, we had to fill it for that brand name, which is usually a lot more expensive. If you filled it for the generic name, you could fill it with any of the brands that have that type of medication. For a generic one that's cheaper, or for the brand name one, either one. And there was a time where some drug companies were actually giving cash bonuses to doctors who wrote a certain amount of prescriptions for a certain brand name. So fortunately, those days are kind of gone, I hope. But yeah, those are the sorts of things that get people outraged about the cost of medicine in this world, this country, I'll say.
But with those cool little technologies, because I worked in a pharmacy too as an assistant, but they make it nice for those interactions, because you know the probably are cardiac patients that have like 20 medications.
Yes.
You know, with these pharmacies that push out so many prescriptions, you know, you don't really get that clinical one-on-one pharmacy, you know, that pharmacist one-on-one. So it's nice when you get a prescription, it'll flag it in the computer system if there's an interaction with your 20 medications and you just got prescribed another one, which is nice. So I guess that's a plus side.
I actually love that. In British Columbia, they had a system called the PharmaNet that went over the entire province, and every single pharmacy in the entire province was linked together. And to your point, you could have one doctor prescribing one thing and another doctor for something unrelated prescribing another thing, and we would know that, so that when they did get that medication, it would flag it and look for interactions and stuff like that, which is phenomenal. So that's one thing I wish we had more of.
Yeah,
I'm not,
because here I think we only have it for controlled substances
yeah, I'm not big
in
on control.
Washington.
I'm not big on government intervening in people's lives in every detail, but those types of things are actually quite good. And when we had people that would abuse medications, particularly narcotics and pain medications, we could see if somebody was multi-doctoring, going to one doctor for one thing and the next day going to another doctor for the same thing. We could see exactly how many pills that they had and when that should be expired and stuff like that, because obviously those kinds of medications are a big problem in society. But yeah, I digress. All right, so application of ECHO continued. So we should focus on function. So not only are we looking at the valve itself, we want to know the function continually of how the EF is doing with the left ventricle and the right ventricle. We're going to look at the pressure gradients, any regurgitations and stuff like that pop up. ECHO should be considered for changes in clinical status, evidence of infection, or reason for suspect valve dysfunction. So if we think that there's anything, and it's usually a symptom or something that pops up that suggests we need to go back and take a look at it, we should use ECHO to do that. Routine follow-up is not necessary unless it's clinically indicated. What does that mean?
Sound like they're showing symptoms, so we
yeah.
need to start following up with it.
Yeah, so basically if something changes, we don't necessarily need to look at them every week until things can't seem to go normal. Typically your follow-ups are like a year, maybe it could be 6 months, it could be a year, it could be every 5 years, or it could just be, you know what, when you have symptoms again, come back in and we'll check it out. Okay. Because it is a cost to the patient, it is a cost to the system to come in continually. Once dysfunction is documented, we do routine follow-up at that point and see and watch it to see if it gets bad. If we get a small dysfunction, are we going to just crack the chest open immediately and replace it? No, we're going to still try to follow it up. We're going to see, you know, if it progresses and gets worse. If it's something that's a big concern, then yes, they will absolutely do that. For example, if they find the aortic valve replacement all of a sudden floating up around the aortic arch, it ain't supposed to be there, right? And stuff like that does happen. Okay. Considerations are made again with pediatric patients because over time the size and the volume of the heart change, and the valve will need to be changed out according to patient size. Okay, so generally speaking, due to the speed of sound, changes in size and appearance can be distorted. Okay, so the exact size and appearance can be a little bit distorted on the exact measurements. Some decrease in gain might be necessary to compensate for these, like on the spectral Doppler, to compensate for those differences. So we need to make sure that our pixels are very tight, that they're not blooming over and stuff like that, because these sizes are critically important for these patients. There will be significant shadowing, as we mentioned, and reverberation. So anything that we can do to kind of work around that structure, the better. 3D can be quite useful, and especially with the en-face view. So don't forget that term, en-face. It's used very frequently within the 3D world. And that's the view of, so we've got our valve, we've got our, maybe our long axis, we've got our short axis. The en-face is looking at it from the end on. Okay, and so that gives us a good perception of how that valve is functioning overall, rather than just seeing one single slice of that valve. Newer stentless valves then can be nearly indistinguishable from normal native aortic valves. So the stentless again suggests that they've taken that metal stent structure out, which happens to reflect very well with ECHO, so we can see where the stent is. The downside is you can't see much beyond it. But the stentless valves are there so that we can scan it better and do more reproducible studies. But again, if you didn't know that that was a valve replacement, you might think it was a native valve. It looks that close. Okay, so TAVR. So TAVR is the stent valve that basically goes in, and this image is just showing the different approaches of how they implant that stent valve. So again, this is an interventional cardiology placement. So just like a mitral valve clip would be, we're actually going in through 3 different types of approaches that they could use. One is transfemoral, which is your standard cath lab. You know, they go into the groin area, into the common fem artery, all the way up into the heart, et cetera. They come back through the aortic arch and place that valve. They balloon angioplasty the native valve out first, and then they place this valve in the correct location. Now, I'm touching on this briefly, and if you do have a copy of the ASC textbook, on page 814, there's actually a section on transcatheter aortic valve replacement, which is what TAVR stands for. Not that you need to necessarily read it. I think it's just that section is actually quite good because it goes over mitral valve clips after that. There's several mini chapters after that. If you have a copy of that, I think it's a good thing to review. Maybe not immediately, but at some point before you do registry, I would take a look at that. But it kind of tells about the details of it, and depending on the valve manufacturer and size and all that, they have a certain distance from the annulus that they have to be placed. What they have to be careful of is not covering up the coronary arteries, obviously. So depending on the manufacturer's exact make of that, you need to kind of adjust for those parameters. So the measurements on these are very, very, very important. And they typically are using 3D and echo to do the measurements needed to appropriately size that for the aorta. What they have found is that the aorta is not as round as we once thought it was. So we do our 2 centimeter LVOT diameter. It was always assumed that that was round. In fact, it's oval shaped, so it's not exact. So the transfemoral approach, again, going through the femoral artery, transapical approach, they're actually cutting in, you can see these diagrams here, they're cutting in through the chest wall and coming straight into the heart through the LV apex. Okay, so they're coming straight in through the apex and placing it up that way, or they can come transaortic, coming up from the right side here and going down, puncturing into the chest through here and into the aorta, straight down and placing it that way. So these are the 3 approaches that they're currently using to place these TAVR valves in the aortic position.
So they actually puncture the aorta there?
Yep. They do.
And then they patch it or they sew it?
I'm not sure what they do with that. If they needed to, I suppose yes, but it's an interventional procedure. So the idea is that they're trying to do it without having to do open heart surgery. And I would think the safest method would probably be to go from transfemoral because of that reasoning. I just me thinking about it, I would think that transapical would be probably second least risky because the muscle can tend to recover, I think, a lot better than the thinner aortic wall with the high pressure. So I'm not sure. I'm not sure what the stats are on those, but
well, I'm just trying to think if they can't use transfemoral, there's obviously blockages leading up to where you need to get through. So I'm like, why would they use the other 2? But it just seems so risky to cut through the heart.
Yeah. Well, the alternative
and especially the high pressure AO.
Yeah, the alternative is they're going to be cracking your chest open and doing open heart surgery. Which, by the way, if they're doing these procedures, they're always ready to do that. They're always ready if something goes bad to crack the chest open and get it done. Those surgeons are waiting, ready to go. Note, I don't think that I put it in here, but note that this TAVR type of valve is actually used in the mitral valve position now also. TAVR was a new thing probably 6 or 7 years ago, and then a couple of years after it really got widely used, it was starting to be used in the mitral valve position. When they started doing these valve replacements, it was only done on the sickest of sick patients. Like these are patients that were imminently going to die if they had nothing done, and they were not good candidates for surgery and stuff like that. That's the people they were allowed to do it on first. They found such success that it's become fairly widely used now, which is great. Okay, general approach here is M mode can be useful to evaluate leaflet movement on valves. This is any valve. Color Doppler we're going to be using to determine the number and severity of jets along with the location of the jets. Now in the valve replacements, what's particularly important is that we see the flow through the center of the valve appropriately, but we're also looking around the outside of the valve annulus to make sure we're not getting that dehiscence and rocking motion and therefore valve leakages around it. We're going to use multiple and sometimes non-standard views. So that's what I was suggesting earlier with the valve structure. Because of the shadowing and stuff that happens, we need to make sure that we're actually visualizing it by doing different windows. Okay, so prosthetic aortic valve in specific. So again, we're looking for valve dehiscence. We're looking for large thrombi or vegetations that might be attached to that. Remember that it's not only bad that we have those vegetations there. Yes, they can break off, they can cause problems, et cetera, but they can also do damage to the valves themselves, and or they could stick the leaflets together, either closed or open, making a less effective valve. We're going to be looking at peak and mean pressure gradients that we'll be obtaining with CW. We're going to have we do have good correlation with the cath lab when we get the peak and the mean pressure gradients. Peak alone by itself actually has poor results compared to cath lab. If the outflow tract cannot be accurately measured, you can substitute the outer diameter of the sewing ring. So in other words, if that patient's carrying around that little card that tells you what valve they have, it will also have the size of that valve. So we actually don't have to measure the LVOT because we know exactly how big it is. And that can be used as a substitute to doing an LVOT measurement. So when we're doing a continuity equation, you can use that exact measurement.
And just a question, they only know that because of the actual valve size they placed?
Yes, correct. But that's the nice thing about putting something in that's man-made is we know exactly how big it is. That's helpful. Doppler velocity index is a dimensionless index that can be used as an alternative to evaluate stenosis. And that formula that I put just underneath that. So the dimensionless index is the peak velocity of the LVOT divided by the peak velocity of the aorta. So those are pretty easy to obtain, one with pulse wave, one with CW, max velocity, one divided by the other.
Can you just clarify? Sorry to interrupt. Which one's PW, which one's CW, just so I know that I wrote it right?
Yeah, so LVOT will always be PW because we need location accuracy, and aorta because it's going to have the higher velocity is accurate with CW. So pulse wave on LVOT, CW through aorta, just like our native valve.
Thank you.
Yep. So that is a ratio between the outflow velocity and the maximum velocity through the prosthesis, if that wasn't clear already. Normal range for prosthesis is between 0.35 and 0.5. Again, this is a dimensionless index, so there is no units on these. Okay, and I understand that that's fairly widely used in the industry currently. All right. So on the aortic valve, so we must assess the regurgitation for pathologic versus physiologic. So again, some of those valves are meant to have a little tiny bit of regurgitation, and we need to determine, is that the physiologic that's supposed to be there, or is that pathologic because of something that's going wrong? That's an important distinction that we need to make. Generally, that central jet is a physiologic, or it could be pathologic just depending on the size of the AI. So if it's a big AI, then that's probably something wrong. If it's a tiny little central one, that's not a big deal, that's expected. Note that the shadowing of the valve, again, can obscure the jet severity. So again, making sure that we get those alternative windows and views to be able to see that completely. It is less of a problem with the aortic valve than it is the mitral valve, because again, the way that a mitral valve is, because of the parasternal long axis view, it kind of hides what's on the LA side of the valve, but my alternative views to see the mitral valve are from the apical positions, which also hides the LA side of it. So it's a little bit harder to see on the back side of a mitral valve replacement. All right, mitral valve itself. Valve leaflets are seen better than the aortic because of the angle. So this is seeing it from the peristernal long axis and the apical. We're actually looking directly into the valve replacement, so they can be seen a little bit better. Leaflets are seated in the mitral annulus, directed more towards the interventricular septum. So again, peristernal long axis is kind of pointing up toward the septum, giving us that better visualization into the valve. Transesophageal might be needed to evaluate any dehiscence on the mitral valve. So if you think it's rocking, they're probably going to do a TEE to more appropriately determine that. So remember, TEE, if there's any questions of thrombus and things like that, TEE comes in behind the LA, which gets a beautiful view from that side of the valve into the valve. The mean pressure gradient is taken on this by doing a TVI of the mitral envelope on the mitral inflow. Again, non-standard views are probably necessary. Pressure half time can be used to evaluate the mitral valve area, but it may overestimate the effective orifice area. So that goes back to your question, Kelsey, on that other one. Using continuity equation, this one has a tendency to overestimate that. Nancy, go ahead.
Mean pressure gradient, the third point up.
Yep.
CW or PW?
CW.
Thank you.
Yep. Good question. Okay, so again, alternatively, that continuity equation can be used to be able to determine flow through the valves and finding that actual valve area. And again, there's mitral valve area via continuity equation in this case. So mitral valve area equals the area of the LVOT. That's the cross-sectional area of the LVOT from our diameter, multiplied by the TVI of the LVOT divided by the TVI of the mitral valve. So similar to aortic use of continuity equation. Okay. So that is those. Let me jump back to our little video. Again, you can access this video. I may not show the entire thing, maybe 15 minutes, but let's take a look at it. I think it's kind of fun to look at. It's fun to see a vendor's perspective because number one, they make it look all nice and aesthetic looking and really cool. Keeping in mind that it is a vendor that's selling it and their purpose is to sell it, and they do. But keep in mind that there is always something that's, everything has a potential issue. Just keep that in mind. Here we go. This might be choppy on your side, so I may not play it very long. Just let me know how it's coming. So you can go
Welcome to this video, your heart valve surgery. The goal of this video is to help you understand the facts about heart valve replacement. Having heart valve disease and choosing a manufactured valve for replacement are life-changing events. During the average life, the heart beats 2 billion times, opening and closing paper-thin valves as it pushes blood through the rest of the body. If the valves are diseased, they must be replaced. And the prosthetic valve that's inserted must mimic the heart valve's original functions as closely as possible. Heart valve surgery is a serious procedure, and the choice of replacement requires careful consideration. This video can help you understand heart valve disease and options for replacement of a diseased valve. When a heart valve fails, repair or replacement of the diseased valve is a life-saving operation. The heart has 4 valves, 2 on the left side of the heart, the aortic and mitral valves, and 2 on the right side of the heart, the tricuspid and pulmonic valves. The most common valve replacements and repairs occur on the left side of the heart. Let's listen to Dr. John Puskis of Atlanta, Georgia, and Dr. Alan Gravy of Tacoma, Washington, explain heart valve disease and its causes.
The most common heart valve diseases are those related to the aortic valve and the mitral valve, the two valves on the left side of the heart. Aortic stenosis and mitral regurgitation are the two most common kinds of valvular disease. The valves are inside the heart. They allow the flow of blood to go in only one direction within the heart. And when they're narrowed, pressures build up inside the heart chambers, or when they leak, pressures and volumes build up inside the heart chambers, and that causes inefficient or poor function of the heart. The things that can cause the problem of either the valves becoming thick and stiff or thinned out include bicuspid aortic valve. The aortic valve is 3 leaflets. That's the way nature designed it. And when it's 2 leaflets, it may open and close perfectly normally early on in life. And yet, over a period of time, we think turbulence and some other factors cause that valve to thicken and stiffen and then to obstruct the aortic position. Rheumatic heart disease or rheumatic fever, sclerosis, which is simply a process of aging, endocarditis, which is an infection of the heart valve. And if we live long enough in general, many of us will have problems with the aortic valve, even if it was perfectly formed at the outset, because of simply aging that goes into these tissues.
To summarize, heart valves can become stenotic from calcium buildup, infection, aging, and other causes to decrease flow. Or they can leak, which is also known as regurgitation. Stenosis and regurgitation can occur together. Both diseases can lead to life-threatening heart failure if not treated with repair or replacement. The good news is that the possibilities for valve replacement are many, and that surgeons worldwide are very experienced in valve replacement.
Valve replacement, of course, means that we take out the patient's own diseased valve and replace it with another valve. We can either replace it with a man-made valve, what we call a mechanical valve, or a valve that is derived from an animal heart, from typical cow or pig hearts. And those are called biological valve replacements. Valve repair is much more commonly done for the mitral valve or tricuspid valve than it is for the aortic valve or the pulmonary valve.
There are several options for replacement. Mechanical valves are manufactured usually from a special form of carbon, pyrolytic carbon. The big advantage of mechanical valves is that they are long-lasting. The carbon will not wear out or break in a patient's lifetime under normal conditions. Because of the carbon, patients with mechanical valves must take a drug known as anticoagulation medication to prevent clotting of the blood.
So the big plus of the mechanical valve again is durability. It lasts forever. The minus is that it requires a blood thinner.
Tissue valve replacements are manufactured from animal tissue and are more like the natural valve. The advantage of these valves is that patients may not have to take drugs to prevent clotting of the blood. Tissue valves will fail after a period of time and will need replacement.
Many of our patients who did have valves put in, tissue valves, in their late 60s and early 70s are living to the point where they now have to come in their late 70s or 80s for a reoperation, which is quite a big thing to go through at that age.
What happens over time is the valve leaflets can tear or stiffen, thicken, and calcify. That seems to happen somewhere between 10 and 15 years in the aortic position. It takes about half as long for it to happen in the mitral position.
How can a patient with limited medical knowledge choose between these options of definitely having to take an anticoagulant or definitely facing a second or third procedure and the possibility of having to take an anticoagulant? A look at valve performance can help make this critical decision. Heart valve performance is measured in 2 ways after implant: complication rates and blood flow. The best valves have good flow and low complication rates. Let's first review complications that may occur with both tissue and mechanical valves. The common complications that occur for both tissue and mechanical valves at low rates are blood clotting. This can be a clot that forms on or near the valve but moves to another part of the body, commonly known as a stroke. Small clots with temporary effects are called TIAs, or it can be a clot that stays on or near the implanted valve, which is known as thrombosis. Bleeding is sometimes caused by a medication taken to prevent the blood from clotting. Excessive blood damage caused by the implanted valve is known as hemolysis. Infection, known as endocarditis, may occur. Leak around the valve can be caused by calcium formations in the heart.
I'm going to jump ahead
Have
here.
to try to emulate this.
This is long. You can go back and
The
watch it.
unique design of the Onyx valve contributes to these low complication rates and pace-setting flow. A natural length, inlet flare, and greater pivot space create a setting for reduced blood damage, which lowers complication rates. The natural length and inlet flare protect against scar tissue ingrowth, a common complication for other valves. This design would not be possible without the properties of an improved pyrolytic carbon, onyx carbon, that has a smoother surface more compatible with blood cells.
We made an orifice that was long and tapered, and we found the optimum length of the orifice that eliminated the kind of turbulence that you would get if you used a straight cylinder for the air.
This chart shows the same level of blood destruction for the onyx valve as that of tissue valves. Mechanical valves will make a noise when the leaflets of the valve close. Sometimes patients cannot hear this noise. More often, this noise can be heard by the patient and sometimes is quite loud. Valve noise studies do not consistently identify one valve as being quieter than another. Tissue valve patients rarely hear their implanted valves. The Onyx valve was designed to be quieter, and Onyx patients often confirm this.
I very rarely hear this thing. Very pleased. I was, thinking, I go in someplace and people be listening to noise, but nobody ever notices it.
There's no noise at all. Clinical results with the Onyx valve were sufficient for the FDA to approve a lower anticoagulation trial that is currently ongoing in the US and Canada. It is the only study of its kind, examining the possibility of lowered INR and the possibility of aspirin and clopidogrel, brand name Plavix, as an alternate to warfarin. The results of this unique trial will be available in the near future, meaning the possibility of a lower level of warfarin or even a non-warfarin therapy for a valve that can last a lifetime.
This is an important trial because it'll be the first FDA trial to explore lower anticoagulation with mechanical heart valves.
If the Onyx valve is able to sustain the patient on a low level of anticoagulation, then this valve might be the valve that would allow a patient to have a mechanical valve without the complications of bleeding and only have a valve for their entire life, essentially a valve for life.
Low complication rates, better flow, less noise, and the possibility of lowered medication or no anticoagulation medication make the Onyx valve an ideal choice for younger patients.
My friend and I went to the beach and I was out battling the big storm waves and diving into the waves. And that was less than 4 weeks later.
I definitely knew that I wanted to not have surgery more than once, so I chose the Onyx valve. Since I recovered from surgery, I resumed endurance sports. I've competed in numerous triathlons, the highlight being the half Ironman in New Orleans in April 2009. Distances on that were a 1.2-mile swim, a 56-mile bike, and a 15.1-mile run. The Onyx valve has restored my quality of life, and I'm really looking forward to the future for myself and for my family.
I should be gone. And what saved my life was that valve. For more information about the Onyx valve.
All right, so you get the idea. I think it's a good one to just kind of show valve structures and stuff like that, how the manufacturers make them, the considerations that they take into play as they create these valves. Just like with our ultrasound systems, we get all kinds of physicists and stuff that get involved, finding the most optimal materials and so forth. So yes, if the patient can have a long-lasting valve with a low need for taking blood thinners and things like that, that's great. Plavix, for example, is a very expensive blood thinner. Coumadin's cheap, but it's pretty rough on the system. So just some things that the doctors and patients have to kind of weigh out as they decide on what types of valves and stuff that they want to end up getting. They mentioned that the noise is obviously an issue. They kind of pointed that out. They're probably advertising, over advertising that somewhat, but I remember scanning a patient once, I think it was like a 25 or 27-year-old guy. And I'm sitting there scanning him on the bed, and I come from a jewelry family. My family has clocks, all kinds of clocks. And I heard this ticking. I'm like, do you have like a analog watch? Like, what's ticking? It was this heart valve. But as I'm sitting there scanning them, I could hear it as if I'm sitting there like this with my watch beside me, listening to it tick. It was that loud. So the noise obviously can be disruptive to patients as well. I think that's a minor inconvenience considering the alternative of not having a heart valve replacement altogether. But those things are important to patients. They're important to deciding whether that's going to be what that patient needs specifically. So next lecture, we're going to talk about when good valves go bad. So when they start to go and dysfunction. So that's kind of a fun one to talk about as well. But any questions on basic valves, the concepts of it, that kind of thing? I think it's a fairly basic chapter. We good? Look forward to part 2.
Actually, I got a question.
Sure, yeah.
Yeah, it doesn't really have anything to do with the valves, but it's something they mentioned in the video. Is left side heart diseases actually more common, or it's just that they're more serious and more likely to intervene?
Yeah, this video is a little bit older now. I can't remember when it came out. I think I probably started putting it around 2014 or 15. But yes, I would say that the studies have certainly been done more on the left heart, and it's certainly the more concerning ones because of the elevated pressures relative to right. But I would say in the last 5 to 7 years, there's been a lot of research being done on the right heart. So I'm not sure that statement would be entirely accurate at this point. I think there's a lot of emphasis being put on the right heart now. So I think it's less true than it used to be, yes. Nancy?
I have a no, it's not on this topic, but it is echo related question.
Sure.
What valves do we do the continuity equation on?
So routinely aortic valve. You can do it on this valve replacement because of the issues that we have around overgaining and stuff like that on our Dopplers with the mitral valve replacement. So those are probably the 2 that you use it on more frequently. Theoretically, I can use it on any valve.
Well, what would the measurements be then for the other valves?
So you'd still have the same valve area. So what we're trying to determine by using continuity equation usually is that we're trying to determine the cross-sectional area of that. So we're looking for the valve orifice on whatever valve we're looking at, and then that would correlate well with the standard numbers for the degree of stenosis. It's just that, like when we do a pressure halftime, we're getting the valve area from that. It would be similar to that on my valve. So yes, it should correlate with our valve size on the other numbers well. What I will say is with the continuity equation, we do an equation called QPQS that we'll talk about in pediatrics more. They use some other techniques now to do that, but when you have VSDs and ASDs, they do the QPQS. QPQS is the continuity equation, but instead of LVOT to aorta, it's now QP is pulmonary, QS is flow through systemic. And so all we're doing is a comparison to that. We can technically use a continuity equation to evaluate the effects of regurgitation even, because what was supposed to go out the LV to head out the aorta went back into the mitral valve, and so there's a discrepancy on those numbers based on what we're finding on the flow side of it. So technically, continuity equation can be used for a lot of different things. Most often used aortic valve. Yeah, but yeah, good.
This question is unrelated to anything we're talking about. What kind of hiking shoes were you guys talking about
Oh, I
earlier?
thought you were going to ask me about politics or something. What kind of hiking
Chacos.
shoes? So we're talking
Those
about
sandals.
what was it? Our Chacos? Is that what we were talking about? So
How's that
Chacos are sandals.
Choco with a C?
CHACO.
Yeah,
Okay,
that's
I just
right.
wanted to look into.
No, taco.
Yeah.
No,
I like tacos too.
wasn't
Let's go
sure.
tacos for lunch.
I just got a new pair last week, I think. So
Yeah, no, I like my Chacos. They're very durable. I actually hike in my Chacos. I'm that idiot that goes out and everyone's like, you got to wear hiking shoes and socks and that. Like I hike in my sandals, whatever. That's just what I
I
do.
hike in mine too.
But they're very durable soles. You do have to break them in to some degree to get more comfortable, but the straps are very comfortable. They conform very well to your feet. But you can the straps kind of go into the sole, but you can kind of adjust it. So it's like one long piece that kind of wraps around your foot, and you can adjust it very good to your foot. So that's what's nice about it. They'd be comparable to like a Teva.
Oh, okay, yeah, because I have Tevas and I was looking at another pair of hiking shoes, but I was just curious which ones you guys were talking about.
Yeah, if you're a barefoot sandal hiker, they're great. Although I'm always told
especially if you go in the water.
Yes, they're great for water. I actually love them for my kayaking.
Hey Scott, I had a question on prosthetics about artificial hearts. Are we going to touch on that subject in this chapter?
No, not in this chapter. There is a section we talked about heart replacement. We don't talk too much about artificial hearts other than just the LVAD, which is a left ventricular assist device. So they actually put a cannula into the left ventricle. It goes into a tube. It has like a little spindle type thing that pushes the blood, and then it pushes it out and bypasses the whole heart going to the aorta. So we do talk about those just briefly, but we don't talk about like I guess that kind of is a mechanical heart. I'm going to draw up a picture here for a second because I'm good friends with a nurse that works in the research wing of Sacred Heart. And her husband is an engineer. See if I can find my picture. He's an engineer and he actually 3D printed a heart that they could test the LVAD devices on. So I'm going to show you what I've got here. I don't think you'll be able to see it very well. That's a 3D printed heart that he created. And the LVAD is the little device that attaches there. It attaches to the ventricle and then it bypasses up and around and attaches to the top of the aorta, past the valves, which is kind of cool. I thought one of these was a video. Anyway, that's what it is. I'm just gonna put my live picture on. You can see it move a little bit, but
That's cool.
yeah, I mean, if you wanted to, I could probably maybe convince him to come in and show it to us.
That would be awesome.
That'd be cool.
But so that tube is kind of a flexible tube, so it kind of bends and stuff. The little device on it that's the actual pump, so it's called an impeller. It's got little like fan blades inside it, and that's what kind of moves things along and pushes it through.
Aren't impellas like super temporary just for certain?
Yes.
Yeah.
Yes, but that's kind of a mechanical heart. We don't get into any much more. I know that they're making more mechanical hearts now. That's all like a complete heart replacement kind of thing. We live in a cool day and age. That's all I can say. That's pretty cool.
Question when it comes to shadowing and artifacts with scanning mechanical valves, which valve is the more harder valve when scanning?
So the mitral valve will be. The reason is aortic valve. Trying to find something I can use to demo. So we'll say the aortic valve, if we're peristernal long axis coming like this, it kind of comes in like this to us. That same perspective with a mitral valve is going to come like this. So it gets more shadowing behind it. This one we can see around a little bit better. we can tilt our beam to see that way. We can tilt our beam to see that way. If you come higher or lower, the mitral one, if I've got regurg happening down here, I can't get high enough to be able to get behind it, and I can't get low enough to get behind it either. From an apical perspective, I'm seeing the valve this way. It's shadowing everything behind it. I can't get around to the other side unless I come again way up top. So the only way to really get around that, if you suspect something, is to do a transesophageal, which then comes from behind it, looking up at it. So mitral valve's harder to see completely around than the aorta, just because aorta we can find windows to approach it differently. Now, seeing the leaflets inside the valve, it's easier to see the mitral valve leaflets on a mechanical valve or prosthetic valve than it is on the aorta. Again, because we can get that direct view into the valve from the apical perspective and somewhat on the peristernal perspective. On the aortic valve, the valve's going to be coming at a bit of an angle. So I'm coming in like this, and there's always a bit of an angle. I can't ever really get shot directly into it. You'd have to come quite lateral on the chest, which can be difficult. So mitral is the answer. Is more difficult. Make sense? Well, there we go.
I have one more question from last topic about Nancy had the same question too. It was the V wave sign or something like that.
Oh yeah, so yeah, I was kind of looking that up. So the V cutoff is what she said. So in that literature that you guys had in that book, it called it the V cutoff. And I was Googling it, and I sent Nancy an article. Nancy, you can either send it around or I can send it out to everybody. It's just an article talking about it, but all it's talking about is when you get those severe jets, because of the elevated atrial pressures, instead of getting that nice rounded parabolic shape, it just becomes more V-shaped and more intense. And the cutoff is occurring because of the elevation. It's cutting off the velocity faster than it would normally allow it to get its normal curvature. That's all that means. What was throwing me a little bit is that the V wave refers to the Wiggers diagram that has the V wave on the Wiggers. But on the echo document, which came from Europe, that particular study that I saw is just they just call it the cutoff sign.
Yeah, they talk about it, but there's like no direct arrows explaining where is the V.
Just the V shape. Just the V shape of your waveform.
Okay.
Yeah, that's all it is. A good question. See, I like that. That means that we're looking beyond Feigenbaum. That's good. Very good. All right. Well, I think we're done. We'll resume on Tuesday. We'll do part 2 of valve replacements.
Thank you.
Yeah.
Thank you.
Thank you.
Thank you, Scott.
Thank you.